Okay, wonderful. Sorry for asking, but I only see my presentation now, so I don't see who's in the audience today. Welcome to Boost CYAC's webinar series. I am Delphine Collin-Vézina, and I will be hosting the webinar today. Before we begin our session, there are a few quick housekeeping points. So, pour les participants qui écoutent cette présentation en français, vous devez cliquer sur le terme floor qui est en bas de votre écran à gauche et vous devez sélectionner French. To see and follow along with the PowerPoint presentation in English, click Presentation on the top left of the screen. Pour ceux qui veulent avoir accès à la présentation en français, vous devez télécharger la version française de cette présentation en cliquant dans la section à droite qui s'intitule Documents. Feel free to download the presentation in both English and French by clicking on Documents on the right. There will be a Q&A during the last 5 minutes of the webinar. To submit your question, please go to the toolbar on the right, click on Messaging and then Participants, and type in your question. You can submit your questions at any time. If you're watching this webinar in a group, please enter the number of participants in the group by clicking on Messaging and then Participants. So we will now begin our discussion. And we have not even kind of a full hour to cover something that is quite exciting and that has grown in terms of the interest in both social services like first line, front line, school settings, child protection, of course, with young offender, and so in many various settings that are serving children and families. And so what I'm referring to is trauma-informed care and how we can build trauma-informed organizations. And today I want to discuss with you the challenges, but also kind of promising strategies to think about when we want to move an organization forward in becoming trauma-informed. I am involved in this area of research. I've been involved for several years, and what is not here in the list of my credentials is the fact that I recently got a very large fund to set up the Canadian Consortium on Child and Youth Trauma. And so I hope that eventually you'll be able to follow this work. It brings together various institutions, organizations, and including a few advocacy centers as well. So welcome to this seminar. I hope that it's going to just echo some of your previous kind of beliefs and knowledge and expertise, and that it might just bring some new ideas, interesting insights. And so let's begin. The webinar today will focus on how complex trauma is one of the many determinants of mental health. We will look at kind of definitions and perceptions about trauma-informed care. We will review some guiding principles when implementing trauma-informed care. And I will just kind of allude to some of the interesting work that's been done to link these principles to the COVID-19 crisis that we're currently facing, and the lessons learned for trauma-informed organizational changes that I have kind of the ones that are standing out for me in this process of supporting organizations moving forward in becoming trauma-informed. So just to get started somewhere, it's very unfortunate, but that's the reality that child maltreatment and different experiences of victimization are very commonplace in our Canadian society. It's not something of the past. It's not something that happens elsewhere to other groups of people. This is here. This is in our own communities. And so, for example, here I'm providing you what I think to be about the best studies that have looked at the prevalence of these maltreatment experiences and victimization experiences. And what we have from both my very dear colleagues, Martine Hébert in Quebec and Harriet McMillan in Ontario, is that looking at very large representative samples of adults who were asked if before the age of 18 they were sexually abused, meaning that they were touched, so non-contact sexual abuse was not included in these studies. So if they were touched or if they were even raped, it's 1 in 5 girls and 1 in 10 boys who reported that they had such an experience before the age of 18. So again, not even considering what we could be labeling as less severe or milder forms of child sexual abuse. So severe forms already, and with this very sadly very high numbers. Another colleague of mine from the University of Manitoba, Tracy Afifi, she looked at the data from population-based surveys, and she was able to demonstrate that when we're asking Canadian adults if before the age of 18 they were either or sexually abused, physically abused, or exposed to domestic violence, it's 1 in 3. It's the exact number is 32% of Canadian adults are reporting that they experienced in their childhood 1 or more of the 3 of these maltreatment experiences. So just very important observation that when we think about maltreatment, this is not something that is rare, of rare occurrence. It's something that is very commonplace. Sadly, it's a sad and upsetting observation, but we must kind of really be quite be solid in this observation, because it means that it's not just the others, it's really everyone who should be really willing to embark in this journey of helping children and youth who are maltreated. The other way that we're presenting this information, this is how the image I use when I work with organizations, is really to think about the backpack and what they're bringing. What are the life experiences that children and youth have accumulated, and now they're in our services. Sometimes we intervene because of a child sexual abuse issue or something that we need to investigate. But are we taking a more kind of global perspective, making sure we look at everything that can be comprised in this backpack? And that includes all different forms of child maltreatment, but it includes also dysfunctional family issues, such as parents abusing substances, with parents presenting with mental health problems. It's also about living in very difficult socioeconomic conditions and kind of really having difficulty to thrive in these difficult settings. It speaks also about community violence. It speaks about systemic violence, gender and race-based violence. So all these ones, if we kind of look at all these different items that I've listed, it means that this backpack can be quite heavy on the shoulders of these little ones, such as in this picture. And so to have that image in mind, I think it's really an important one. And we might not know everything about that backpack, but are we remaining very curious about wondering what is in that backpack that is slowing down this child and not helping the child becoming who he truly or she can truly be. I'm not today pretending that trauma is the unique determinant of any kind of mental health or other issue that a person can present with. And so there's really a wide range of biological or environmental factors that influence mental health outcomes. And so I just really don't want to diminish kind of the importance of the other factors. But as you can see here, there's really a great acknowledgement in today's research and today's practice as well, that there are several components that will predict mental health difficulties, short-term and long-term. And life events, stress and trauma, there's certainly kind of one very a category on its own, and there's a complex interaction between all of these different factors, including, of course, genetic and other individual factors, and as I was mentioning, kind of the broad range of poverty, hardship, and oppression. So today we're going to zoom on trauma, but not to dismiss the fact that there are multiple factors that need to be taken in consideration. And what I'm bringing you kind of on trauma, and more specifically on complex trauma. So it's not always agreed upon how we can distinguish between simple and complex trauma. And simple doesn't mean that it's not severe, because if someone has a huge car accident and their life is really at stake and they're fighting for their life, this is quite severe, but that would be considered simple trauma because that's very contained and very a unique point in time where this person was abused, or not abused, but was victim of a violence, violent event. When we think about complex trauma, we want to recognize that it's not just well contained, it's almost like every moment's life in a person's trajectory, that it's very embedded in very profound relationships that are meaningful for the individual. So it will be prolonged, it will go on for many months, many years, in very close relationships, usually caregiving relationships. So those are traumatic events that are really interpersonal in nature. It's a human being kind of not acting nice towards another human being. It's not just bad luck. And so the dual reality is that it's going to provoke outcomes that are much broader than what post-traumatic stress disorder usually covers. So it's not to say that, again, that simple trauma is just post-traumatic stress disorder and complex trauma is something else. It's much more kind of really complex than that. But when we think about very prolonged relational-based traumatic events in a child's life, then it's not just going to be about having nightmares or feeling hypervigilant. It's all different aspects of that person's life will be impacted by the experiences of maltreatment that have been endured. And so the multiplicity, the severity, complexity of these outcomes will be noted. So with that in mind, then, when we think about trauma-informed care, what is it exactly that we mean? And I'm pretty sure that you've encountered that, or you've noticed that it's a buzzword, and many people do use that term. It seems to be kind of the way to go. And so today I just want to unpack that a little bit. What it is not, because I can start with that, it's certainly not just a list of things that organizations just need to go through and to adopt, and then it's kind of done. So it's not just activities, it's not just like different tools, concrete tools. It's a bit broader, and it speaks more to an overall climate in the organization. So it's not an easy checklist. It's also not a magic wand. So it won't solve all the problems. If there's high turnover in an organization, even if you bring in the best trainings and the best support system, it's going to be difficult. So there's sometimes systemic problems that need to be looked at before we can fully develop a TIC approach, because the TIC won't solve it all. And I'm saying TIC, I'm sorry, it's an acronym for Trauma-Informed Care. And I hope it's not the flavor of the day. I hope it's not like something that is very popular now, but it's going to be kind of outdated very soon. I hope it's more like attachment theory. Attachment theory is still relevant. We talk about it now. It seems we can't imagine caregiving relationships without that theory in mind. So it has a major impact in how we perceive human relationships. So I hope that trauma-informed care is kind of similar. There will be other information coming in. There will be new ways of looking into children and youth challenges, but that it won't replace trauma-informed care. Trauma-informed care will remain as kind of the main platform from which we build new insights. So what it is, I'm proposing here just one definition because there's several. This is one that really resonates very well with me. So trauma-informed care is an approach. So it's really a vision to policy and practice that includes awareness of the prevalence of trauma, understanding the impact of trauma, and commitment to incorporating those understandings in policy, procedure, and practice. So really, that's the idea that it's not a technique, it's not a program, it's much broader than that. It is the approach, it's the vision that the organization wants to commit to doing with their clients. So we usually say that trauma-informed care is like the lens. It's what's going to inform and really mold the how you're going to structure all the other activities. So it's not that activity per se, but with these lenses, you're going to think about your clients differently, and you're going to think about your programming differently. So that's the interesting piece. What I like about also trauma-informed care and how it's been implemented thus far in various settings is the fact that it doesn't replace what we've been doing for years. We will look at what we've been doing for years and just see if it makes sense. Is it from a clinical standpoint and the needs of those who were presenting with complex trauma? Does it make sense to continue with that programming? Does it make sense for all our clients? Are there clients that we're unable to help? And then what can we change? So I like the idea that it's not as if it's coming as a savior with, this is the new way of doing things. I think it would be wrong to go that route, because among the people participating to this webinar today, there's a wealth of experiences and expertise and critical thinking, and so that's really not to be put aside. So TIC should be seen, trauma-informed care should be seen as something that will just enrich these experiences, expertise that you already have, and not to replace all of these many years of experience you have. Another way of thinking about the trauma lens is that if we don't adopt a trauma lens, what's going to happen? And so we have a few people who've written about that, and especially Harris and Fallow. They were about the very first ones to talk about that in a more at the organizational level. What they're saying is if we don't do that, if we don't adopt the trauma-informed lens, then the presenting problems can be misunderstood, misdiagnosed, and resulting in potentially harmful approaches. So if we think about a child who has ADHD-like symptoms, and it's quite obvious this child is not attentive and really on the go, and has difficulty waiting in turns, and it's just very difficult to manage. But if we don't take time to think, okay, is this child really suffering from a neurodevelopmental disorder that is called ADHD, and that's possible? Or do we take time to think, is this child doing okay in terms of, is this child under a lot of stress? Are there things going, happening at home that can maybe just exacerbate or even create these symptoms? If a child the night before going to school didn't sleep because there was a lot of violence in the home, maybe that child won't look super attentive in the classroom, but is it really truly ADHD, or is it trauma related? So the idea is, again, not to think that, okay, so then all children should not be receiving ADHD diagnosis, not at all. It's just to be more cautious and more reflexive and take time before jumping into conclusions. And so we can be more maybe accurate, and the answers that we're going to give for people to heal and to thrive might be also more effective. And so what they're saying here with another group of people is that if, in trauma-informed services, professionals are not required to treat trauma, and rather their approach they approach their work with the understanding of how common trauma is among those that they serve and how challenging it might be to establish a therapeutic connection. So working with a trauma-informed lens doesn't necessarily mean that you're going to do kind of a psychotherapy work, such as trauma, TFCBT, trauma-focused cognitive behavioral therapy, which is a very well-known and very effective psychotherapy option for children, for instance, who were sexually abused. But when you adopt a trauma lens, it doesn't mean that this is going to be your role, or maybe the child is not ready for this kind of therapy. So that means that a trauma lens can be adopted by everybody. It's not just psychotherapy focused. It's how we talk to children from everyone that's involved in our settings. I want to show here kind of a study that we conducted in Quebec, and that really shows that there can be sometimes a disconnect if we don't use a trauma lens. So that was done kind of about 10 years ago, and we recruited children, in fact, teenagers who were in residential care facilities. So all these children were taken in care. And in Quebec, there's the possibility of to take a child in care due to behavioral issues. So not necessarily a maltreatment incident that was investigated and substantiated, but the teenager has enough behavioral issues and parents are unable to fix that or to be kind of proactive and take steps. So those are the children that you have here, with a mix in terms of gender, also quite a good range from 14 to the very end of 17, just before they were aging out of care, and good diversity in terms of racial group, with children, youth coming from very different ethno-racial backgrounds. We asked them, and we got all the permission to do so. As you may imagine, that was not an easy study to get approved by research ethics boards. We did ask about 5 different types of maltreatment they may have experienced before coming to care. So we were asking about physical abuse, emotional abuse, sexual abuse, physical neglect, and emotional neglect. And so this was done through a questionnaire that is extremely well known and well validated, that is called the Childhood Trauma Questionnaire. And that's, so there are several questions, and based on the answers that participants give, then we can rank whether it falls in different categories based on severity. So we could have none or minimal. So for sexual abuse, it's really none. But for other forms of abuse, because in the general population, people were endorsing kind of somehow some of these items, such as, I was put down once in my childhood by my parents. That's many people might have said yes, and because of that, so there was kind of a range from which we were saying that this is minimal, and so categorized as if it was absent. But otherwise, it's from low to moderate, moderate to severe, and severe to extreme. And at the right, you have the total from low to moderate and to severe to extreme. So when it's considered as present. So it's 62% overall among that sample who reported that they were physically abused. And again, not considering those very kind of small items. So not that many false positive, like people that we would consider as having been physically abused, but maybe they were not truly. So that's a very solid instrument. Emotional abuse, 68%, sexual abuse, 38%, which is still very, very high if you think of the numbers I gave at the very beginning. So that's kind of twice as high. Physical neglect, emotional neglect, also kind of in the 55, close to 60% range. So when we were asking them, kind of really giving them a voice about what had happened in their lives before, there were many of them reported that abuse was part of their childhood, unfortunately. When we took that information and just transformed it in yes or no, no severity. So regardless of severity, with the 5 forms of maltreatment we were covering, it's 83% of the sample reported at least one form of maltreatment. And as you can see, a majority of them accumulated different forms of adversity, with 5 being the maximum. And it's 1 in 5 kids in this sample reported the experience of all 5 forms of child maltreatment we covered. And we did not even include experience related to exposure to domestic violence and all other forms of victimization. So that's so high. And when we had also a scale that was looking at post-traumatic stress disorder as a potential disorder that they were presenting with, and 25% of them had scores that were higher, above the clinical threshold. So that was very kind of an eye-opener kind of study, because showing the extent of trauma experiences that these kids had suffered. But what we did that was even more interesting, and then showing how we can miss it sometimes in our lens, is that we went into their files, their child protection files, and look at why they were taken in care. So the reasons for child protection involvement. We were not expecting a perfect match, because again, in Quebec, we can take children in care because of behavioral issues. But the numbers here, they really show that if we only rely on the reasons for child protection involvement, we're kind of missing a great proportion of the child maltreatment experiences that these children have endured. So 83% of these kids were in care because of their behavioral problems. So very much putting the responsibility on their shoulders. Neglect for 1/4, and it adds to more than 100, because in Quebec you can have a maximum of 3 reasons for child protection involvement in the same time period. But you can see that physical abuse, emotional abuse, sexual abuse, they're almost like invisible if we think about the reasons for child protection involvement. So there's a disconnect between what these young people were able to report and what we actually know if we don't go beyond just the reason for referral. So adopting kind of a trauma lens is therefore a shift in culture, because it means that we'll do more than, for instance, just documenting the reasons that these kids are referred to child protection. We assume it's not going to be enough, it's going to be the tip of the iceberg, and we need to do more. But that's quite a huge undertaking, and it's not an easy one. It's a process that really tries to shift completely the focus from what's wrong with this kid, and to really have much more attention given to what's happened to this kid. It's not just all of a sudden that a child is becoming defiant or very angry or very violent. So what is happening? What's happened in their lives? And what can we do to help? So removing some of the pressure and responsibility off the shoulders of these kids, and putting that responsibility on us as professionals, as as a society, as a system. And so that's a comic that I really like, because it's the idea that we're bringing the notion of trauma up front. And as you can see here with the analogy of the elephant in the room, I'm right there in the room and no one even acknowledges me. So can we make sure that it's going to be discussed, it's going to be recognized, that we won't talk about children who have mental health issues as if maybe this is a child who's depressed, and not to go beyond that, to go beyond the label, to go beyond just the behavior, and to wonder what's happened in that child's life. And maybe there's some explanations there. So why it's difficult, of course, is, as I was mentioning, it's not just a list. So it's not just one way of conceptualizing what is TIC. And trauma-informed care can be extremely successful in one organization. And then if all the lessons learned can be transferred to the other organization, but it doesn't mean that it's going to work the same. It's not like a program. You can have great fidelity, you know what you're going to provide in each of the sessions. A lens is like it's vague and much more difficult to define the boundaries of that, and the principles. They're also very, it's for me, I think what is great about this approach is that it's very flexible, but with flexibility comes also some uncertainty on how to implement really a trauma-informed care approach. And so what I'm suggesting for the second half of this presentation is just that we take time to think about these very guiding principles. So because you're probably coming from very different systems and different organizations, what I thought about doing was just to kind of reflect on what are the guiding principles if we want to start thinking about trauma-informed care, and how the extent to which it's already there in our organization, the extent to which there's some improvement that needs to be done. And so I invite you to think about these four our rules, kind of contrasting what you can already observe in your organization and what you feel could be kind of, okay, let's put up a challenge and do something more and do something better. So this rule that was proposed by the Substance Abuse and Health organization in the United States is so following the 4R rule, and that what is really important is to have an organization that will find ways to help people realize the impact of trauma and the importance of providing healing opportunities. We'll also have strategies to recognize the signs and symptoms of trauma in clients, in families, in staff, and others involved in the system. There will also be different strategies put in place to respond to clients' needs by fully integrating knowledge of trauma into policies, procedures, and practices. And the last, and as important as the other ones, if not more, to resist very actively to kind of, and make sure not to reactivate new trauma. So I'm going to describe each of these 4R and see how that can be enacted in one organization. So the first one about to realize, this is usually done through training sessions. So to offer sensitization training sessions, sensitization sessions, training sessions, but to really think about training everybody, to train the person who's welcoming clients at the door, to the psychotherapist, very expert psychotherapist. Everyone should get a common understanding and common awareness towards trauma and the impact of trauma. So to realize is really, above everything, to realize that complex trauma is a relational trauma. It's happened in very significant human relationships, and so it involved for the child a sense of betrayal. There was trust that was put in some adults or caregivers, and unfortunately, these adults, they had their own issues, and maybe that was very difficult to be a parent, and some forms of abuse and maltreatment and neglect that were unfortunately perpetrated on that child. So it's relational trauma. It's not bad luck. So it will have impact at very, very different levels. A child not feeling secure in a relationship, a child not feeling that they're worthwhile, that they think that they're not worthy of any love. They might think that the world is dangerous. They might use dissociation as a way to deal with stressors because they could not fight or run away when they were abused. They have difficulty managing their emotions because there was no one to really help them to scaffold that learning. So it's relational trauma, and this has to be fully recognized and realized. So we need to help children and youth reconnect with caring adults who are different from those in their past, and to really help them to find ways to have restorative relational experiences. And so it's not going to happen very kind of suddenly. If a child is coming with 12 to your service with 12 years of mistreatment, it's going to take probably more than just a few sessions before this child even begins to believe that it's possible sometimes that adults can be nice and they're real and it's true, it's authentic. There's not a hidden agenda. There's not an adult who sometimes is nice, sometimes is just completely losing it. So it will take really a long time because they worry they're going to be hurt again, and they're just worried that it's going to be still a very shameful, very difficult, hurtful experience. And so each relationship is an opportunity to heal. In some of the group homes I've worked with, the person who was there every day to cook for the children in the group home was probably the most significant caregiver for these children. She had a special place in their heart. She was kind of making that place look like a home. And they could, sometimes they were coming to her to talk and not going to their child protection worker. And that's the beauty of these restorative relational experiences, that really, who's that person who can help the child believes that there's another kind of way to be in relationship with others. So anyone is so important, everyone, I mean. And so to really realize that above everything, there's really, if a child gets to a point where there's a little bit of secure relationship that is formed, that is going to be one of the most impactful factor against negative experiences. And so that can take so many different forms and format. The second R is about recognize, and then it's for an organization to really make sure they have ways to document in a very thoughtful way the signs and the symptoms that are related to trauma in their clients. So that's an evolving reality. It's not a set in stone. So how can we monitor the evolution of these symptoms, or maybe ask, when we meet the person, what is the backpack about? What is in that backpack? But also to have continuous monitoring if we think that a child is still experiencing different forms of violence. So you have here it might be the best source of information to look at different kind of different measures. And I'm suggesting one in particular that is called the Child Welfare Trauma Referral Tool, because it covers really a wide range of domains that are impacted by trauma. It helps to have a checklist to really monitor, but it's not something that you need to have specific credentials to be allowed to use. It's a tool that is really doesn't require to have a specific training. But on that website, so if you remove the Child Welfare Trauma Referral Tool from the hyperlink you have here, so this is from the National Child Trauma Stress Network website, and there's a wealth of information there that I suggest you go and look for. But the only thing I want to emphasize is how important it is, though, to use these detection tools very carefully. There has been a push towards using trauma questionnaires and routine screening in any kind of setting. So I think that we need to be quite well balanced and not to go too far in doing the opposite of what we were doing. There was the elephant in the room, and now we're asking everybody. We need to be mindful that these are questions that are extremely sensitive, that can provoke upsetting feelings. And so people need to be well trained. So that's my first point here. We can't ask these questions just like a checkbox. So in your childhood, were you sexually abused? In your childhood, were you physically abused? You can see that it just doesn't make sense. The person needs to be very well trained, and that it's going to be used for a purpose also. So that's the second point. Are we asking that just for the sake of asking, or do we have services to offer? And if we don't have services to offer, we need to balance things out and really think about, are we just opening the Pandora box and then the person is left without any kind of support? That could cause harm. So to be mindful about that. And to make sure that we also take time to think about, so when I'm asking these questions, is it clear for the child how it's going to be used? Who's going to have access to this? To ensure that we limit also the risk of stigmatization, that it doesn't become like the information that everyone has and the child was not necessarily aware that it was going to be shared in such a way. About responding, so this is the part that I'm going to spend probably just a little bit more time than the first two ones, not because they're all equally important, but this one is probably where we have most questions. So what do we hope when we say respond? Again, we respond to various needs, but what we want to respond about the most is the need for emotional and physical safety. So these are children that need to feel that they're safe. And if we can reach that point of helping them feeling safe in their classroom, feeling safe when they come for their 1 hour appointment with us, they're safe in their family, in their foster family, in their new foster family, they're safe in their community, then these are children that will be back on their kind of more normative trajectory because they can put all their energy and all their resources to just growing and be a child rather than to be hypervigilant, looking out for dangers, and just be on the lookout. So the conditions, we need to look physically. Is it safe enough? So physically, are we sure that we're putting everything in place so that a child is not at risk of being bullied in a corner? Are there places that are very just difficult for a child physically to feel safe? And then, of course, to be present more emotionally so that we're sensitive and we try as much as we can to be empathetic and not too much reactive. So this is what I'm going to focus on now. The model that I'm proposing here is based on the attachment theory. It's called the secure base, and it was created in the UK. What I like about it is that it's how to form a secure base when you're not the primary caregiver. You're not one of the parents. This is not your role, but you're still a pillar. If you're a teacher, if you're a social worker, if you're every role that a person can have is certainly one where a secure base can be provided to a child, even if you may not become really an attachment figure. So to help us think about, so what are the conditions for this kind of secure base to be promoted? There are 5 different elements. The first one is availability, and it seems like really obvious, but it's about being available and making up time, even if a child is more difficult. This is probably when he needs us the most. So I know it's difficult. So for instance, we work with that model with foster families, and we try as much as possible to kind of revisit, for instance, when they say, well, the child had such a bad day that I'm not going to read a story tonight because kind of to a certain extent, the child doesn't deserve it. He wasn't nice to me, and so forth. So we try to reframe it and to say maybe the day was really hard for that child, and then it became very difficult, and we can acknowledge that. But can we kind of go back to saying, well, I'm still there as an adult. I'm still present. I still want to be with you. And can the foster parent comes in and say, well, we had a difficult night, but I'm willing to read a story still because I would like to end this day in a much better way than kind of the past few hours that we had that were really not great. So can we show availability that is beyond just like as if it's something that a child is desertive of, that it's kind of a gift that we give. It should not be related always to good behaviors. It's something that it's free. Our availability to a child is always very free, so they can count on us. Sensitivity is the capacity of caregivers to be sensitive to the child, so to go beyond the behavior, to be able to say, well, your behavior was difficult at dinner, but I wonder what happened, during the day. Maybe something really upsetting happened to you. So that might explain why it was difficult for you to behave over kind of our meal. And so to really help the child to be sensitive, so it's not to give an excuse to all the behaviors, but it's to be able to kind of go look beyond and offer some interpretations to the child. Acceptance is about really building a child's self-esteem, being able to really highlight the child's strengths and qualities, but also in a very nuanced way. We're not good at everything. And so traumatized children tend to have such a negative view of themselves, or the opposite. They can be super narcissistic and very, as if they have an inflated sense of self. We don't want that. We want something that is nuanced. And it's okay to have a conversation about what we like, what we don't like, and what we're good at, what we're not super good at, and that's okay. So to really help a child in terms of acceptance of oneself, and to project this image of the child, so that there's unconditional love and affection that comes with this discussion, that it doesn't remove any of the affection we have, because we're just noticing that there's something maybe a bit difficult for that child. The second to last is cooperation. And I like this one because we often hear in our organizations and treatment plans that children need to become more autonomous and independent, and especially when we work with teenagers. But we need to remember that some of these children, they didn't have a chance to cooperate, so to rely on others, to be in this scaffolding relationship, to have a person who's really willing to help them, take by the hand, and show them the way, so that eventually they can be autonomous and independent. So the worry here is that if we push them too much towards independence, what they're not learning is to be in that connection, in that interdependence with others, that you can do a little bit on your own and it's okay, but when you need help, it's great to go and seek for support. And this is really what they need most to learn. It's this kind of nuanced relationship and dynamic and dance that we have with others. And the last one is family membership, but here family is really broadly defined. It could be family or group membership. It's how we can promote a child to really develop a sense of belonging, that they're part of a group that they can be proud of, that they have activities, they have values, or they have, different elements in common with that group, and make sure that we help a child to develop this true sense of feeling one in together with other individuals that are meaningful in his or her life. And so another way of presenting it, and we're getting to kind of the end of the presentation, but it's how we can respond to a child so that it doesn't this child is not caught up in this loop, this survival loop of being very hypervigilant and looking at triggers and being so all the energy and all the resources are taken up by this vicious circle, so they cannot accept caring or take in information. And so what I presented before, it really aims to stop this survival loop. Another way, and I really recommend that you look at this website, northstarpath.com. So those accessible infographics, this one I've used it a lot. For those who are listening in French, the French version also exists, about reframing the behavior and how we can help people get more on the right side to understand that the child maybe is behaving that way because he can't, and to remain curious about why that child is not able now to behave in a better way, rather than to kind of be in a judgmental way. And as you can see here, that you will kind of, if we have the understanding that the child is just not doing it because he wants to be defiant, and that there's a purpose, that the child is really making a choice, then we might use just rewards and punishments because we think that the child is in control of his behavior or her behavior. And so that's an interesting, I think, infographic that you can use in your own setting. And so the last one is about how we can resist retraumatization. And so it's very unfortunate, but children that are in care, children that are in our services, they might be exposed to further trauma. And so we need to constantly monitor and make sure that we have an open dialogue, that we really have a space for children so they can share what is happening, and so that they don't fear the repercussions always of having that discussion. And it's something that is done because we care about them, because we want them to be safe. It's also where we need to make sure that all the decisions we take, they're really always for the good of that specific child. And here you have examples like, should we keep siblings together when we place them in foster care? That's a huge question. And for some children, it's yes, they should be together. That's really a protective factor. For others, it's not, because they're just retraumatizing, one another by being together all the time. And to give them separate spaces where they can thrive is the best option. But it's not an easy decision with perfect threshold. So we need always to be very reflective and to put our own societal standards a little bit on the side, and to look what is the best option for this specific child. To make sure that we don't rush out, that we take time. And that's not always the case. I know that it's difficult. There's a pace in our work that is just so quick. But to make huge decisions like should we place a child or not is one that will have a life, an impact on that child's life trajectory forever. So we need to allow ourselves, unless we think that there's an immediate risk of danger, should to allow ourselves, because there's a potential for retraumatization if we rush things out. To make sure that we supervise children, to kind of have really a sense that in our settings, the risk of violence and bullying and other forms of trauma won't happen, or really are unlikely to happen. And the very last one is that if we work in different settings that are using behavior kind of control measures, such as restraint or isolation or expulsion from school, for instance, that we think that it's very limited to extreme and dangerous situations, because these are kids that really not need to have other forms of abusive actions towards them. Sometimes it's necessary because the child is really at risk. But can we make sure that we've tried any other option before going the route of the most extreme forms of reactions? And so in this PowerPoint, you will see a few more information, and I won't have the time to go through all of them, but they're more like support material. So I want to bring you, so those are all other guiding principles that you can find applied to the COVID-19 global pandemic. So that might be of interest to you. This is an open access paper. So the guidelines that were presented just on the slide before, they're applied to trauma-informed care in the context of COVID-19. And I just wanted to introduce to you, if you're interested in looking for a model, I think that the ARC framework that I did not create myself, but I'm just fond of, is really one very interesting approach. You can purchase the book, and when you purchase it, you have the copyright, you have the right to photocopy the material, and there are tons of activities, milieu-based, individual, family, very different kinds of activities that you can use. It's like those are all building blocks that really help a child get to a point of trauma integration but through really very concrete steps that you can engage with. And that's just a very, I think, a very well-rounded intervention framework. And if you're interested in this ARC model, here I have a few questions that are from the model itself and that you can use to think about, so what is the level of trauma-informed care implementation in my organization? And I'll just stop here with two resources. So the ARC framework from the authors of the model, they created some documents to think about, again, the COVID-19 pandemic and how we can think about those youth with a history of complex trauma and how we can help them. And you also have some indications or elements for reflections about telehealth and how we can provide very solid trauma-informed care, even if we're not meeting always our clients in person. So I think I'll stop here because the other slides are really self-explanatory, and I will have time for just a few minutes of questions. So I will stop my presentation and we'll look at your questions if you have some here. And so, oh, that's good because it's just, thank you so much. Questions go here. So I will try to see where the questions are. So for now, I don't have any. So that's good sign. And thank you so much, Wendy, for your nice comment. This is very nice. So if you don't mind, now you probably see my screen still, so I can just use that the 2 minutes I have, given that I can't see any specific question, just to go through the lessons learned. And so those are takeaway messages. So it's really a teamwork. And what I've seen in my own experience implementing trauma-informed care is that the more people are buying into this, or they're interested and curious, not everyone needs to be super in favor of trauma-informed care, but that they're curious, the easiest it is to really get it started. And it's very important to get the people in decision-making positions on board. It's important to have a good plan. To just offer a one-time training is not sufficient. You need really to have a plan where you think about, so how are we going to train our staff? What kind of support are we going to provide? Supervision or case consultations or coaching? Do we have a stable leadership? Or again, is it like really a lot of turnover? So that would be really difficult. Oh, I have a question, so I will just stop here to answer that. Do you have a book for supporting adults? Absolutely. You should look at the new book that was published by Christine Courtois, and it's called Treating Complex Trauma in Adults. Like, it's really, and there's a new version that was, I think, released last year. And Christine Courtois is really just a stellar psychotherapist who's worked with trauma survivors for decades, and I recommend her book really to a great extent. And so just second to last, that we need to take care of the carers. It's demanding, it can be exhausting to be working with a trauma-informed lens, because we're always in that curious, mindset, but that means that we have a lot of uncertainty and not being sure and questioning ourselves. Sometimes it's a little bit more tiring than to have like just the schedule and not to think about adapting the schedule to everyone's needs. So to really have a system that will support the carers, and I use that term to encompasses really all different caregivers and people that can play a role in building a secure base for children. And the very last one is that you can have the best, in French we have this beautiful triad that can be translated by knowledge, know to, and kind of soft skills. And it's about these soft skills that we need to be as absolutely focusing on, because we can have the best knowledge, we can have the best activities and tools, but if we don't have this overall attitude that is very positive towards trauma-informed care, it's going to be very difficult to make that change. And so it's the end. And I think I'm just good with time. It's 2 p.m. My time again in Montreal. I hope you're doing okay. I hope that this presentation was of interest to you. You can email me. My email address appears just at the very end of the presentation. And I wish you the best, and especially that everywhere in Canada we have a COVID-19 crisis that really gets resolved very soon. I hope you're healthy, you're safe, and keeping your spirits high. So thanks for your attention.